All right, welcome to this explainer. We're going to jump straight into a high-stakes clinical mystery today, one that perfectly captures the incredibly complex world of seronegative spondyloarthropathies. We're talking about a group of pathogenically linked chronic inflammatory diseases. They share a distinct genetic predisposition, negative serology, and an overlapping spectrum of joint and organ involvement. But to really understand how these diseases operate in the real world, we need to look at a very specific and very urgent patient presentation. Picture this. A 24-year-old architect rushes into the ER. He's got severe lower back stiffness that is literally waking him up at 3 a.m. every night. Strangely enough, a hot shower and a quick jog actually make it better. But bed rest? That makes it worse. His lab work shows an elevated C-reactive protein of 38, but his rheumatoid factor and anti-CCP are strictly negative. Plus, he's got this swollen, incredibly tender right sausage digit on his second toe. Now, this right here presents a massive diagnostic trap. If we misdiagnose him and prescribe systemic, high-dose corticosteroids, we risk triggering an explosive, life-threatening psoriasis flare. On the flip side, if we just write it off as a mechanical strain and tell him to rest in bed, his spine will undergo progressive, irreversible fusion. To save our patient's spine, here is our exact roadmap for today. 1. The clinical puzzle. 2. SPA versus rheumatoid arthritis. 3. Diagnosing the disease spectrum. 4. Stepwise management and treatment. And finally, 5. Recent advances and guidelines. Section 1. The clinical puzzle, diagnosing the undiagnosed. So let's look at the immediate situation our architect presents. When he arrived, junior residents actually threw out 5 totally conflicting diagnoses: lumbar disc herniation, mechanical back strain, seronegative rheumatoid arthritis, gout, and fibromyalgia. Figuring this out isn't just some academic exercise. Look at this stark warning from the clinical guidelines. Never give high-dose systemic oral corticosteroids to a patient with suspected psoriatic arthritis. Tapering them can literally convert stable plaque psoriasis into life-threatening generalized pustular psoriasis, otherwise known as von Zumbusch. Avoiding this trap is quite literally a matter of life and death. Section 2. SPA versus rheumatoid arthritis. Fundamentally different frameworks. To treat our architect correctly and dodge those catastrophic pitfalls, we absolutely must understand the major difference between his condition, a spondyloarthritis, and other inflammatory joint diseases like rheumatoid arthritis. Think of it using this brilliant architectural analogy. Rheumatoid arthritis, it's a disease of the synovial lining, known as synovitis. It's basically like dirty water pooling inside a living room carpet. It just slowly destroys the joint. Spondyloarthritis, on the other hand, is a failure at the suspension bridge anchor points. It targets the enthesis, the exact spot where heavy tendons and ligaments drill directly into the bone. In SPA, mechanical tension causes inflammation and erosion, but then something really unique happens. The body tries to repair it with abnormal calcification, creating syndesmophytes that can fuse the entire bridge frame into a solid, immobile block. Let's zoom in on the cellular level here and see how this builds. It all starts with mechanical stress at insertion sites, triggering microdamage. Then, genetic factors like HLA-B27 step in. Those heavy chains misfold in the cell's manufacturing center, the endoplasmic reticulum, creating stress that drives robust IL-23 production. Next, local resident immune cells respond to that IL-23 by unleashing a sudden, massive surge of IL-17 and TNF-alpha cytokines. This cytokine storm first activates osteoclasts, causing bone erosion, and then, paradoxically, unleashes the osteoblasts to form new bone. And that is what tragically fuses the spine. Section 3. Diagnosing the disease spectrum, the many faces of SPA. Now that we've got the suspension bridge failure down at a cellular level, let's explore the clinical spectrum and the diagnostics we use to catch these diverse diseases. You see, spondyloarthritis isn't just one disease, it's an umbrella term. These pathogenetically linked diseases all share the HLA-B27 genetic predisposition and negative serology, but they present across a very distinct clinical spectrum. You've got axial spondyloarthritis, which impacts the spine. You've got psoriatic arthritis, linked to skin and nail psoriasis. There's reactive arthritis, which is a sterile synovitis that pops up weeks after a GI or urogenital infection. And finally, enteropathic arthritis, which is directly tied to inflammatory bowel diseases like Crohn's or ulcerative colitis. Notice how distinct each of these subcategories really are. Look at the HLA-B27 association. It is incredibly high, 85 to 95% in axial SpA, but then it drops to around 40 to 50% for psoriatic arthritis. We also see some very unique extra-articular features here. A patient with axial SpA might show up with acute anterior uveitis in the eye, whereas a patient with reactive arthritis might present with classic triad symptoms like conjunctivitis and urethritis. Now, as we try to diagnose our architect, we have got to dodge some common diagnostic traps. The biggest one for sure, confusing mechanical back strain with true inflammatory back pain. Inflammatory back pain actually improves with exercise. It gets worse with rest, and it classically wakes patients up in the second half of the night. That's a huge telltale sign. Also, a quick tip for MRIs, don't get fooled by bone marrow edema caused by sports or degenerative disc disease. True sacroiliitis requires edema in very specific periarticular locations. And here is an absolute gem of bedside wisdom. If you want to confidently diagnose seronegative polyarthritis, you've got to follow the senior attending rule of thumb. Always check these 3 hidden sites for occult psoriasis: the scalp, the umbilicus, and the intergluteal cleft. Finding just a tiny hidden patch of psoriasis in one of these areas can immediately reroute a patient's diagnosis and save you from making a catastrophic treatment error. Section 4. Stepwise management and treatment. Targeting the axis. Okay, so our architect is firmly diagnosed on the SpA spectrum, thanks to his enthesitis, inflammatory back pain, and that swollen sausage digit. But how do we actually go about treating him? The protocol here demands a strict, stepwise approach. For axial disease, your first line is always full dose, continuous NSAIDs. Think naproxen or celecoxib for 2 to 4 weeks, alongside dedicated physical therapy. But if the patient has an inadequate response and their disease activity score remains high, we then seamlessly escalate to advanced targeted biologics like TNF inhibitors, IL-17 inhibitors, or JAK inhibitors. Watch out for this massive clinical pitfall. Notice the stark contrast between managing axial versus peripheral disease. Conventional synthetic DMARDs, like methotrexate, work wonderfully for peripheral joint disease, but they have zero efficacy for pure axial symptoms. Why? Because they target cytoplasmic folate synthesis in dividing cells. They do absolutely nothing to suppress the enthesial signaling that drives the spinal fusion. For pure axial symptoms, if NSAIDs fail, you must bypass conventional DMARDs entirely and jump straight to biologics. You also have to tailor your treatment perfectly to the patient's exact subspectrum. Take enteropathic arthritis, for example. Non-selective NSAIDs are a huge red flag here because they disrupt gut mucosal integrity and can precipitate severe inflammatory bowel disease relapses. Furthermore, etanercept, which is a common biologic, is practically useless for treating IBD and anterior uveitis because it fails to neutralize membrane-bound TNF in granulomatous tissue. You always want to choose monoclonal antibodies when gut or eye disease is present. Section 5. Recent advances and guidelines. The paradigm shift. Let's look at the recent clinical trials and guidelines that have completely rewritten the playbook on these structural remodeling therapies. These pivotal trials represent a fundamental paradigm shift. We aren't just broadly dampening inflammation anymore. We are now striking directly at the bone-forming drivers of the disease. For instance, the B-Mobile trials proved the superiority of dual IL-17A and F inhibitors, like bimekizumab, for suppressing enthesial axial inflammation. Meanwhile, the Select Axis trials brought targeted synthetic J1 inhibitors right into the fold. On the psoriasis front, the Discover trials validated IL-23 inhibitors for amazing skin clearance. And finally, the Maximize trial showed how effectively IL-17A inhibitors treat axial involvement specifically. Backed by these major international society guidelines from groups like ASIS-ELAR, GRAPPA, and NICE, clinicians now have highly validated domain-specific approaches. We no longer just treat all spondyloarthritis the same way. We map the exact domains affected, whether it's axial, peripheral, skin, or gut, and we deploy targeted therapies like IL-17 inhibitors to shut down that inflammation way before any structural damage occurs. So, connecting it all back to our 24-year-old architect, how does this new understanding rewrite his future? Well, by recognizing that his 3 a.m. back pain and swollen toe were the signs of a suspension bridge failing, and by actively avoiding the dangerous traps of steroids or standard DMARDs, you can step in with max-dose NSAIDs and escalate straight to targeted biologics. You literally have the power to stop those osteoblasts in their tracks, keep his spine perfectly intact, and let him live a completely full, active life. The real question is, the next time a patient walks in with seemingly disconnected inflammatory back pain and a swollen toe, will you catch the hidden connection in time?